Hello and welcome to the 2018 ABR Non-Interpretive Skills Study Guide Review Series. This is David Larson at Stanford University, and thank you for joining me again today. We're continuing where we left off in the study guide in practical safety applications in radiology, and we're now continuing with management of intravascular contrast media. So first question, what is the osmolality of iso-osmolality contrast media and that of low-osmolality contrast media? Well, serum osmolality is approximately 285 millimoles per kilogram. Therefore, iso-osmolality contrast media, as the name implies, is about the same as serum osmolality. And really the only agent that we use for that, for iodinated contrast, is VisiPAK, which is more commonly used for intra-arterial injection. Low osmolality contrast media, it has an osmolality of approximately double that of serum osmolality. And agents that we use that are low osmolality agents include OmniPAK, IsoView, UltraVist, OptiRay, and Oxalan. Next question, describe the two types of adverse reactions to contrast material. Well, the two types of adverse reactions are physiologic and allergic-like. So physiologic reactions are dose-related. They're unlikely to be severe when low doses are used, which is pretty much always, and they're believed to represent direct toxic effects of the injection. Whereas allergic-like reaction, for that, the mechanism is not completely understood in most patients. One thing that is known that it generally does not consist of the characteristic antigen and IgE antibody response. It does not require sensitization due to prior exposure like other allergic reactions do, and thus it's termed allergic-like rather than allergic. Regardless, patients present with symptoms that are similar to true allergic reactions, and for allergic-like reactions, these are idiosyncratic and not dose-related, unlike that of physiologic reactions. Next question, describe mild, moderate, and severe physiologic reactions. Okay, so for physiologic reactions, mild, moderate, and severe, actually for both types of reactions, mild, moderate, and severe, refer to the following. For mild, this is self-limited with signs and symptoms without progression, whereas for moderate, the signs and symptoms are more pronounced and they may require medical management, and for severe, signs and symptoms are potentially life-threatening and can result in permanent morbidity or even death if not appropriately managed. So for mild physiologic contrast reactions, this includes nausea, vomiting, flushing, warmth, chills, headache, anxiety, altered taste, mild hypertension, and spontaneously resolving vasovagal reaction. Probably the most common of these is a metallic taste and the feeling of warmth. Moderate signs and symptoms include protracted nausea, chest pain, vasovagal reaction that requires and is responsive to treatment, and then severe reactions include vasovagal reaction resistant to treatment, arrhythmias, seizure, hypertensive crisis, pulmonary edema, and cardiopulmonary arrest. The latter two are very rare, especially the severe category, extremely rare. Next question, describe mild, moderate, and severe allergic-like reactions. So again, mild is self-limited, moderate is more pronounced, and severe is potentially life-threatening. So for allergic-like reactions, mild reaction includes a few hives, pruritus, limited cutaneous edema, itchy or scratchy throat, nasal congestion, sneezing, and stuffy nose. For moderate reactions, this includes diffuse hives, diffuse erythema with stable vital signs, facial edema without dyspnea, and wheezing with mild or no hypoxia. And severe allergic-like reactions includes diffuse edema or facial edema with dyspnea, erythema with hypotension, laryngeal edema with stridor and or hypoxia, wheezing with hypoxia, severe hypotension and tachycardia, pulmonary edema, and cardiopulmonary arrest. One thing to note, pulmonary edema and cardiopulmonary arrest may imply either severe physiologic or severe allergic-like reaction. Next question, what is the most common type of reaction to contrast media? The most common reaction is a mild, self-limited physiologic reaction, again, warmth, metallic taste, and nausea. Allergic-like reactions are less common. They're counted in less than 1% of injected patients, and most of these are mild. And severe life-threatening allergic-like reactions are extremely rare. The incidence is estimated to be between 0.01% and 0.04%, so that's about 1 in 2,500 to 1 in 10,000 of injected patients. Next question. What risk factors increase the likelihood of adverse reaction to contrast material? Well, the main risk factor is a history of prior allergic-like reaction to the same class of contrast material, whether that is iodinated contrast or gadolinium-based contrast. And that's approximately 5 times the risk of the general population once you have had a prior allergic-like reaction to that same class of contrast material. Also, other allergies and asthma increase your risk to about 2 to 3 times the risk of the general population. A couple of notes. First of all, allergies to shellfish or other iodine-containing products, such as betadine, are not believed to increase the risk of allergic-like reaction. And also, a history of gadolinium-based contrast material is not believed to increase the risk of allergic-like reaction to iodinated contrast agents above that of other allergies, and vice versa. So these don't necessarily cross over to the other class of contrast material. It's just within that class. Otherwise, it's considered to be an allergy like any other allergy. Next question. What considerations regarding iodinated contrast should be made for patients with thyroid cancer or hyperthyroidism? All right, this is an important one to know. These patients, once they're diagnosed with thyroid cancer or hyperthyroidism, may need to be treated with a radioactive iodine, I-131, and so these patients need to not receive iodinated contrast in the 4 to 6 weeks before treatment, because non-radioactive iodine load saturates the thyroid gland and then renders the radioactive iodine treatment ineffective. And so it's not uncommon that patients who receive this diagnosis in an effort to further evaluate the thyroid gland undergo contrast-enhanced CT, or at least an order is placed for a contrast-enhanced CT, and so you need to watch out for that and make sure that that does not happen, because they're going to need to likely treat that cancer with radioactive iodine. Next question. Who should undergo premedication for contrast media? Well, policies vary by site, but it generally is agreed that premedication is indicated at least in patients who have had a previous moderately severe or severe allergic-like reaction to the same class of contrast material in the past. Premedication likely reduces the risk of contrast reaction in high-risk patients, but it does not eliminate it, so you need to just be aware of that. There is such a thing as a breakthrough reaction, and that is a contrast reaction that occurs despite premedication. Next question. Describe the 2 most common contrast premedication regimens. Well, there are 2 regimens that are commonly used, the Greenberger and the Lasser regimens. Greenberger is more common. That consists of oral prednisone 50 milligrams administered 13, 7, and 1 hours before the administration of contrast, as well as oral Benadryl 50 milligrams 1 hour before. And the Lasser regimen includes oral methylprednisolone 32 milligrams 12 and 2 hours before administration of contrast. It should be noted that the timing of the administration of the steroid is not precisely known as to when it needs to be given to have its effect. It is known that the regimens that have the 12 or 13 hour timing, that has been proven to be effective in reducing contrast reactions, but that just 1 and 2 hour oral regimens alone have not been proven effective. So it's probably somewhere between the 12 to 13 hours and 1 to 2 hours. Next question. Describe a commonly used rapid corticosteroid premedication regimen for contrast reaction. Well, again, the timing isn't exactly known, so if a patient needs to undergo a contrast-enhanced study rapidly, then one regimen that has been suggested is IV hydrocortisone 200 milligrams every 4 hours until the study is performed, and preferably at least 2 doses are given. So at least it's preferred that it's at least 4 to 5 hours that it started before the study is done, as well as oral Benadryl 50 milligrams. And so it's important then to weigh the benefit of the patient waiting for a premedication regimen versus the risk of contrast reaction, or obviously looking for other studies that might be able to be done. Next question. What benefits have and have not been proven regarding corticosteroid premedication regimens? Corticosteroid premedication regimens have been proven to reduce the number of mild allergic-like reactions in average risk patients, but there's no definite evidence that premedication protects against moderate, severe, or life-threatening reactions. However, the rarity of these events makes this difficult to prove. So the point is that we don't really know for sure how it protects against moderately severe or life-threatening reactions, but we do know that it does decrease the number of mild allergic-like reactions. Next question. When breakthrough reactions do occur, what is their typical severity? Well, 10% of the time they're more severe than the initial reaction, 80% of the time they're similar to the initial reaction, and 10% of the time they're less severe than the initial reaction. In other words, most of the time when there's a breakthrough reaction, it's similar to the initial reaction. And the point is that premedication does not generally just decrease the severity of the initial reaction. It either completely removes it, or if you have a breakthrough reaction, it's usually the same or similar to the previous reaction. Next question. Can a patient who has a breakthrough allergic-like reaction be reinjected in the future? The answer is generally yes, if the breakthrough reaction was mild, and many such patients actually will not have a repeat breakthrough reaction. And then if the breakthrough reaction does occur, similarly as to before, it will most likely be of the same severity as the previous breakthrough reaction. So again, it's generally if the breakthrough reaction was mild, then you could go ahead and do it again in the future, administering premedication. Next question. What is considered to be the greatest risk of corticosteroid premedication to patient health? Generally, the greatest risk is that associated with the delay in the performance of the study. So the delay in diagnosis, or the increased costs, or increased exposure to hospital-acquired conditions. In other words, the risk to the patient, direct risk of the patient from the steroids is pretty low. You can have transient hyperglycemia, which can occur from 3 doses of corticosteroids. Usually this is mild and it's rarely clinically significant. Other complications from a short burst of corticosteroids have been reported, but they're very rare. In fact, they're basically anecdotal. These are things like exacerbation of infection, peptic ulcer disease, steroid psychosis, and tumor lysis syndrome. So in other words, this short burst of corticosteroids generally has a very low direct risk. Next question. What is the difference between post-contrast acute kidney injury and contrast-induced nephropathy? Well, post-contrast acute kidney injury is a general term describing sudden deterioration in renal function after IV contrast administration within 24 to 48 hours. So this is regardless of whether or not contrast is actually the cause. So therefore, post-contrast acute kidney injury is a correlative diagnosis. So it's correlated to but not proven to be caused by IV contrast. And this is an important distinction from contrast-induced nephropathy, where this is a sudden deterioration in renal function that is caused by IV administration of contrast. So contrast-induced nephropathy is a subset of post-contrast acute kidney injury, but contrast-induced nephropathy is a causative diagnosis. Next question. What error in estimated contrast-induced nephropathy occurred in most published papers before 2006? Well, the error was that contrast-induced nephropathy and post-contrast acute kidney injury were considered to be equivalent in these papers. In other words, they did not include control groups of patients who did not receive contrast material, and many papers studied patients who had undergone intra-arterial rather than IV injection. And so intra-arterial injection may be associated with other additional risks such as atheroemboli to the kidneys. It has nothing to do with contrast. And when it is associated with contrast, it may expose the kidneys to more concentrated, greater concentrations of contrast media. So basically, this led to substantially overinflated estimates of the rate of contrast-induced nephropathy, and it's now known that most cases of post-contrast acute kidney injury are not due to contrast-induced nephropathy. So the thinking of this has changed over the past 10 years or so. Next question, what is the current understanding of contrast-induced nephropathy? Well, the current understanding is that if it occurs at all, it is most likely to develop in patients who have acute kidney injury or severe chronic kidney disease, meaning a GFR of less than 30. The existence of contrast-induced nephropathy in patients with a GFR of greater than 45 is very unlikely, and the existence in patients with GFR between 30 and 45 is even questionable. Special precautions are therefore currently only advised for patients with acute kidney injury or severe chronic kidney disease. Possible additional risk factor that may exist is the administration of multiple doses of contrast media within 24 to 48 hours and or cumulative doses above some threshold, for example 280 milliliters. And that is based on the dose toxicity relationship that's been shown after coronary arteriography, but not conclusively shown for IV administrations. So this is a theoretical risk. Next question. According to the Acute Kidney Injury Network, AKIN, what is the definition of AKI, acute kidney injury? Well, the historical definition is an absolute increase in serum creatinine from a baseline of at least 0.5 or a 25 to 50% increase in baseline serum creatinine level. AKIN suggests that regardless of the cause, acute kidney injury should be diagnosed whenever there is, number one, absolute serum creatinine increase of at least 0.3, or number two, percentage increase in serum creatinine of at least 50% above baseline, or number three, a reduction in urine output to 0.5 milliliters per kilogram per hour for at least 6 hours. So one of these three criteria is currently the definition of acute kidney injury. Next question, what is the usual clinical course of post-contrast acute kidney injury, including contrast-induced nephropathy? Well, the clinical course is usually a rise in serum creatinine beginning within 24 hours of contrast material administration, peaking at about 4 days, and then usually returning to baseline by about 7 to 10 days. Most affected patients are non-oliguric, and permanent renal dysfunction is unusual. Next question, what diseases or conditions predispose patients to acute kidney injury, and do they also predispose them to contrast-induced nephropathy? Conditions that predispose patients to acute kidney injury include diabetes, dehydration, cardiovascular disease, diuretic use, advanced age, multiple myeloma, hypertension, and hyperuricemia. And it is currently thought that they probably actually do not predispose patients to contrast-induced nephropathy. Next question. What is the risk for patients with end-stage renal disease on chronic hemodialysis? So the risk associated with contrast media for patients with end-stage renal disease on chronic hemodialysis are that patients could experience additional renal function compromise, but honestly such a risk is this time theoretical. Many nephrologists agree to give IV contrast if necessary. There's also the possibility of developing fluid overload because of the hyperosmolar contrast media, but there is no requirement to time the chronic dialysis with patients on chronic dialysis to occur immediately before or after contrast administration. You don't need to time the dialysis. Just go ahead and give the contrast and go with the regular dialysis schedule if you're going to give contrast. Next question. What prophylactic strategies should be considered for patients at risk of contrast-induced nephropathy? Well, the first strategy is questioning whether another modality can be used, such as ultrasound or MRI, that may not require contrast. When contrast is required, it is recommended that we use the lowest dose of contrast possible. There's also a strategy of using volume expansion with isotonic fluids, normal saline or lactated ringers, and that's 100 milliliters per hour for 6 to 12 hours before and 4 to 12 hours after administration of contrast. Other strategies that have not been proven include sodium bicarbonate and N-acetylcysteine, and strategies that have been discredited include mannitol, furosemide, and theophylline. And a possible strategy that is possibly emerging is that of high-dose statins, because they appear to be effective in reducing the risk of post-contrast acute kidney injury before cardiac catheterization. So that one is out there being studied. Next question. Describe how patients on metformin who need to receive IV contrast should be handled. Well, metformin is the oral agent of choice for treating many patients with diabetes, and it's contraindicated in patients with severe renal dysfunction because a very small percentage of those individuals develop lactic acidosis, which has a high mortality rate, roughly 50%. But it should be noted that there is no direct interaction between iodinated contrast and metformin. It's all related to acute kidney injury. So if a patient receiving metformin develops acute kidney injury, there is a possibility of lactic acidosis. The ACR recommends that no precautions are currently necessary for diabetic patients on metformin who receive contrast media unless the GFR is less than 30 milliliters or the patient is undergoing unless the GFR is less than 30 milliliters per minute per 1.73 meters squared, or the patient is undergoing arterial catheterization because of the risk of emboli to the renal arteries. So in these cases, we hold metformin for 48 hours after contrast administration, and we only restart it after normal function is reestablished. So again, only when there is a known renal compromise, or if they're going to undergo arterial catheterization. So in summary, metformin is not a risk factor for developing contrast-induced nephropathy, but patients who develop renal failure while taking metformin are at risk for developing lactic acidosis. Next question. What does the evidence show about the risk of fetal exposure to iodinated contrast? Well, there's no evidence that maternal exposure to iodinated contrast is harmful to the fetus. It does cross the placenta, but there's no evidence that fetal exposure increases mutagenesis or cancer risk, or affects renal or other organ function. Next question. What does the evidence show about exposure to iodinated contrast in breastfeeding mothers? Well, about 1% of IV contrast enters the breast milk, and then about 1% of that is absorbed through the infant's GI tract. And that represents much less than 1% of a typical iodinated contrast dose, but it can alter breast milk taste. So in summary, there's no evidence of any adverse effect on the infant. However, it is generally recommended that lactating mothers be informed of this phenomenon, and if they're concerned, mothers may abstain from breastfeeding for 12 to 24 hours, where they may pump and discard the breast milk that's produced during this time. That happens on a fairly regular basis. The reality is it almost certainly does not need to happen, but it just does for the comfort of the mother. Next question. What is the rate of contrast extravasation? The rate is about 0.1% to 0.9%, so it's uncommon, but it does happen. It's more likely to occur with poor catheter insertion technique, but it still is possible with proper technique. It's more likely to occur when using distal sites, such as the hand, wrist, foot, and ankle, rather than the antecubital vein, and is more likely in lines placed greater than 24 hours before the administration of contrast, and it's more likely when there were multiple punctures into the same vein. Risk factors of higher contrast, there's a risk factor associated with higher volume contrast administration when the patient can't communicate, such as infants and children, elderly, and all patients with altered consciousness, and severe illness and debilitation. In other words, you can administer the contrast and not realizing that it's extravasating until later for these individuals than for other individuals. Next question, how should contrast extravasation be handled? Well, unfortunately, there's little that can be done to mitigate the effects of contrast extravasation when it does happen. In general, the strategy is to elevate the affected extremity above the heart to decrease hydrostatic pressure and apply cold compresses to the site. Some things that are ineffective are to attempt to aspirate the contrast media or to inject other medications. Then once it does occur, if it warrants it, you should obtain surgical consultation for concern for compartment syndrome or tissue necrosis. Those signs and symptoms include progressive swelling or pain, which is the most common and most concerning sign. Also decreased finger mobility, altered tissue perfusion, including delayed capillary refill, change in sensation, skin ulceration, and blistering. And it should be noted that no extravasation volume exists above which surgical consultation is considered mandatory. Basically, it's monitoring for these symptoms. Symptoms may not be evident immediately after extravasation occurs. It may develop gradually over time, so patients should be followed until symptoms resolve, improve, or at least remain minor. And if a patient with improving or stable symptoms is discharged, they must be given clear instructions to seek prompt attention for severe injury and must be given the signs and symptoms to be watching out for. So again, including worsening pain, failure of existing pain to improve, decreasing extremity motion, loss of sensation or paresthesias, and any evidence of skin breakdown. Okay, I think we're going to go ahead and stop there. We'll continue with this section in the next video. Again, thank you for watching. This is David Larson reviewing the 2018 ABR Non-Interpretive Skills Study Guide.